We are pleased to be joined by Dr. Robert Jyung, attending physician at University Hospital, and his colleague, Dr. Nicole Raia, audiologist at University Hospital. Good to see both of you. We are here to talk about hearing loss. 20% of Americans have experienced or do experience some form of hearing loss?
I'd say that's true, but we have to be clear that the 20% represents many different types of hearing loss.
What types?
Well, there's a basic breakdown. You have what we call nerve damage, which is sensory neural hearing loss, and there are mechanical types of hearing loss called conductive hearing loss. And those two things have very different underlying causes, and they have very different forms of treatment.
How does one know?
Well, we turn to our audiologists and we ask them for help.
So we see patients from birth to the geriatric population. Every newborn in this country receives a newborn hearing screening. So that gives us a newborn hearing screening. We call it universal newborn hearing screening.
What does that tell us?
That tells us, it teaches us about children who are at risk for hearing loss.
Right.
We screen children using tube measures. We use a different measure for well babies versus babies that are in the NICU,
right, and
determine if a follow-up appointment with an audiologist for a diagnostic evaluation is warranted. So
I'm curious about this. Given the fact there are different kinds of reasons, there are different reasons for hearing loss, the treatments that are available today, doctor, versus say 10, 15, 20 years ago, dramatically different?
Some things are still similar. For example, there are surgical ways to address mechanical types of hearing loss. Some of those haven't changed too dramatically, but
what is the biggest change? Or some of the biggest changes?
I would say the efficiency and the technology that we use to address some of these surgical issues has improved a lot. But technology has helped us to address the sensorineural hearing losses as well. And the biggest change over the last few decades has been the cochlear implant.
The cochlear implant, I hear a lot about that. What is it?
Well, it's a device that is surgically implanted, and it is stimulated from the outside through a microphone that picks up the sounds and converts it into electrical signals through a processor. And that is passed through the skin into a receiver stimulator that then sends the signal in a processed form down to electrodes that are in the cochlea, or the inner ear.
So it's in your head?
It's a two-part system. So there's the part that Dr. Jyung implants in the skull, and then there's the outside part that you put on and take off every day, the processor, and that's managed by the audiologist.
Is it replaceable? What do you...
Well, what changes primarily is the external processor. So as the technology improves, the companies can bring out newer and better products with different features. The part that's implanted is generally kept in for very long periods of time, although there is the potential to upgrade those if need be.
Who's the candidate for that?
Generally people who are profoundly deaf and who can no longer benefit from hearing aids.
Talk children. What kinds of issues are they facing early on, and how does it potentially impact their ability to learn? Because anecdotally, I've heard that there are many children, or there are a significant number of children, who have hearing issues that may not be picked up in the way they need to be picked up, and the way they suffer from an educational point of view is just profound.
So in order to be able to learn to speak, you really need to have good access to sound. So those are the children that we are picking up on very early with our newborn hearing screening, are the children with moderate to profound sensory neural hearing losses or permanent conductive hearing losses. The children we're missing are those mild hearing losses or the losses that occur later, whether they be permanent conditions or conductive hearing losses from children, say, that get fluid in their ears. We know that 2 to 3 out of every 1,000 children born in the United States has a permanent type of hearing loss.
Hold on.
Between 2 and 3 children.
Out of every 1,000?
Out of every 1,000 born.
Has a permanent?
Yes.
That from birth or at any point?
No, from birth.
From birth. Mm-hmm. But the other one, you said from fluid in the ear?
So children are at higher risk for middle ear effusions just because of their anatomy and the way that their anatomy differs from an adult. And 8 out of 10 children that are school age will experience some kind of transient hearing loss or a temporary type of hearing loss.
So the whole issue of ear infections in children, we react as parents. where is the danger point when it comes to issues of hearing loss?
So a lot of middle ear infections in kids can resolve with antibiotics, sometimes just with observation even, but there's a type of disease that can come from chronic ear infections. That's what we call chronic otitis media. And they can have holes in the eardrums, they can have chronic drainage, and they can develop another disease process called a cholesteatoma, which is an invasive process where skin erodes into your temporal bone.
How do we know this?
Well,
Does a
usually
pediatrician pick that up?
they may or may not. Sometimes these things will not go recognized immediately. So a history of drainage out of the ear that occurs spontaneously and regularly, that has a bad smell, that maybe even have blood tinging it, these are all things that need to be paid close attention to.
So I don't want to say this wrong, an osseointegrative device. What is it and who's a candidate for it?
So an osseointegrated auditory implant is a different type of device as compared to a cochlear implant.
It is different.
It is different.
What is it?
It is a titanium post that is placed behind the ear, again, by Dr. Jyung or the otologist. And then there's a processor that is placed. The difference is in how it works. It works through vibration. So we know that we can stimulate a healthy or normal working cochlea through vibration. So we're bypassing your middle ear to stimulate the inner ear directly.
Who's the candidate for it?
A person who has a permanent conductive hearing loss, either bilateral or unilateral, or a patient who has no hearing in one ear, what we call single-sided deafness. We can put the processor on the side that does not hear and send the information to the better hearing ear.
Before I let you out of here, I'm curious, from a prevention point of view, are there any things that we can do to prevent or reduce the chances that our children will have a hearing loss, that we will have a hearing loss? Anything we can do?
Well, you can certainly put restrictions on how much they overuse devices that put too much sound into their ears. So the personal listening devices, headphones, the earbuds, and listening to music.
You're not a fan of overuse?
Well, I think I really appreciate music, but I think that you can appreciate it without hammering your ears with too much sound.
Anything else on this?
Parents don't realize that many MP3 players have a parental control option that can be password protected. Or you can buy headphones that don't get louder than the recommended volume.
So we as parents have a responsibility here as well. Beyond what is potentially genetic, beyond the things that we cannot control, we need to be aware of what we can control and influence and take responsibility.
Absolutely.
Well said. I want to thank both of you for coming in and talking about very important issues that have to do with our hearing, our children's hearing, and what we can and cannot influence, but what we need to know. Thank you, both of you.
Thank you.
Appreciate it. Stay with us. We'll be right back. Thank you very much.
The preceding program has been a production of the Caucus Educational Corporation, celebrating over 25 years of broadcast excellence, and 13 for WNET, NJTV, and WHYY. Funding for this edition of Caucus New Jersey has been provided by Josh S. Weston, Investors Bank, Berkeley College, Suez, Delta Dental of New Jersey, Johnson & Johnson, and by the New Jersey Office of the Insurance Fraud Prosecutor. Transportation provided by Airbrook Limousine, serving the metropolitan New York, New Jersey area. Caucus New Jersey has been produced in partnership with TriStar Studios.